Hello, everybody. My name is Mathieu Jabaudon. I'm an anesthesiology and critical care doctor from France, and I'm very happy to participate to this conference. Very thankful to the organizing committee for inviting me. But of course, I'm also a bit sad not to be with you physically in Beirut. And I wish you a great conference and all the best in general, especially in these tough times. So here are my conflicts of interests, and it was a good opportunity also to show you a nice landscape from where I live in Clermont-Ferrand, France. So I will mix voluntarily in this talk ARF, acute respiratory failure, and ARDS, especially because it's very difficult sometimes to distinguish both settings. And actually, the definition of ARDS has many limitations, and this does not help such a distinction unless we could improve the definition itself. It may not be this important to distinguish both, especially because, in my opinion, the syndrome itself, the ARDS, is poorly recognized and identified in the clinical settings, as it has been shown by this large observational study published a few years ago. It may not also be a big problem to mix this population, especially because the current proposed definition for ARDS is expanding the Berlin criteria to use in patients under non-invasive ventilation, high-flow oxygen therapy, and to use also SpO2 FiO2 ratio instead of PaO2 FiO2 ratio if in cases where the arterial blood gas is not available. So what about the management of such patients? I would start first by the most important, I think, is treating the cause of the patient. In case of bacterial pneumonia, antibiotic therapy. In case of peritonitis causing the acute respiratory failure, is surgery to treat peritonitis. And all the rest that I will cover in this talk comes, in my opinion, as a second line, because if you are wrong in this treatment of cause, then the patient will be worsening for sure. You should always use fluid management in a very reasoned manner, and ideally by monitoring the patients, as any excess fluid received by the patient who would not need any will be worsening, probably lung injury. So to start, the question of non-invasive strategies of oxygen support, and especially high-flow oxygen therapy, which has gained interest since a few years, and especially this first big trial showing better survival in patients treated with high-flow oxygen compared to conventional oxygen therapy and or non-invasive ventilation. Non-invasive ventilation, meaning pressurizing the airways, is also actually used as a first line in many patients with ARDS, as shown again by this large observational study. But you should be aware, of course, of a high risk of failure, and meaning requirement of intubation in patients. And this risk will be higher in patients with more moderate or severe ARDS compared to those with mild ARDS. And indeed, high flow oxygen also comes with its important rate of failure and need for intubation. And you could keep in mind that around 30 to 40% of patients treated with high flow oxygen or NIV will require intubation. And the big challenge here is not to delay intubation, because it can worsen clinical outcomes. So there are now current guidelines on ARDS, but that can be also applied to patients with ARF. And regarding high flow oxygen, these guidelines recommend their use. It's a moderate recommendation, but it can be tried as a first-line therapy. There's no recommendation possible to make with non-invasive ventilation except for the specific setting of patients with hypercapnic acute respiratory failure, where NIV is most interesting. So this is a good strategy to start with, especially if your patient is clinically stable, if it tolerates these therapies, and if their oxygenation is not worsening. In case the patient is deteriorating, this is something you could monitor closely by looking at the respiratory rate, for example, because a patient with a high respiratory rate, when you start this non-invasive ventilation or high flow oxygen strategies, should decrease actually in case of success. And if the patient stays polypneic despite these treatments, then probably you would need to turn to invasive ventilation after intubation. And what about the settings of this ventilation in case of invasive ventilation, but which also apply in non-invasive ventilation? Tidal volume first. The current recommendation, and this is a strong recommendation based on many studies, a lot of evidence, is to limit tidal volume to a range of 4 to 8 milliliters per kilogram of predicted body weight, not the true weight of the patient. And by doing so, the benefit is probably due to a limitation of the inspiratory plateau pressure below 30 centimeters of water. There are many studies, I won't go across them, but just to mention this very old animal study from 1963, published in Nature, showing that all mammals actually on Earth breathe around 6 ml per kilogram of tidal volume. And so we are just maybe applying the natural rules in mammals just to our patients also. So what about the positive and expiratory pressure, the PEEP level? The guidelines are a bit disappointing here because we will see later what are the limitations. But if we want to see the benefits of PEEP, as you can see on this movie, in an ex vivo lung model of animal lungs, actually. But when you start to apply a PEEP, it just started right now on the movie, you are gaining lung volumes, you are recruiting lung areas that were not well aerated before. And so you are increasing basically the functional residual capacity. And this is the goal of the PEEP in this setting. Of course, this is to balance with the risk of over-distending the lungs. And this is all the difficulty of setting PEEP in these patients. The guidelines, as I said, are a bit disappointing, in my opinion, because they only recommend to use a PEEP level of at least 5 centimeters of waters without further details, and especially without any recommendations on how we could titrate PEEP levels in a given patient, because there's a lack of evidence supporting one or the other methods to do so. And so the recommendation is a bit broad, actually. In practice, there are multiple options, but one of them could be to use these tables combining PEEP level on one side and FiO2 on the other side. These tables of lower or higher PEEP, they were used a lot in many studies from the US clinical trials network. No difference shown in clinical outcomes between both approach, lower versus higher, but this is something quite pragmatic that you could use at the bedside. The other option that I would suggest is looking at respiratory mechanics in your patient, and especially to driving pressure. Driving pressure is basically the difference between the plateau pressure and the PEEP level, and it means the distending pressure above the PEEP level that is required to generate the tidal volume. So it gives you an idea of the compliance indeed of the system, and the compliance being the ratio between tidal volume and driving pressure. You could also think of the driving pressure as the tidal volume that is personalized to a given compliance of the respiratory system in a given patient. So why could it be interesting in these patients, especially those with ARDS? It comes from this very large retrospective and post-hoc analysis of prospective cohorts from the US clinical trial network, showing that above 15 centimeters of water, mortality will increase. So this threshold is not this robust, but this is probably a maximal setting that we could keep in mind. And the idea is that whatever the change in tidal volume and or PEEP that you are making in on your ventilator, as far as it decreases driving pressure, or at least it keeps driving pressure stable, then you would be on the good direction and not being increasing mortality in your patient, because probably you're recruiting the lungs with the PEEP and you're not going to distend them. And so this is why driving pressure may be a readily accessible tool to guide your ventilator settings in these patients. There are indeed multiple approaches that have been proposed, but evidence lacking to make any more detailed recommendations. You could, of course, use transpulmonary pressure estimation by monitoring esophageal pressure. You could use multiple imaging methods, probably to assess recruitment and or distension, and other calculations, for example, ventilatory ratio or mechanical power, that are also very well associated with the risk of ventilator-induced lung injury. But as you got it, the main challenge in this management is to balance our settings between recruitment, what we want, and the over distension of the lung, what we don't want. And in addition, of course, to the hemodynamic risks that you're taking when you're increasing too much intrathoracic pressure. What about other settings in mechanical ventilation? FiO2 is a big question. There are conflicting results from studies comparing restrictive and liberal approaches, and maybe my main message, pragmatic message today would be to target something around 94% of peripheral oxygen saturation. Respiratory rate should be adapted to allow hypercapnic, permissive hypercapnia in most patients with a possible cutoff in arterial pH of 7.2, unless patients are at risk of increased intracranial pressure and or right heart failure. And this is important in this case to monitor the IE ratio, allowing sufficient time for respiration with an IE ratio of at least 1 to 2, and monitoring the risk of auto-PEEP by applying an expiratory pause to make the pressure stabilize, and a pause of a duration of 3 to 5 centimeters is often recommended in this setting. So if the strategies you're using, either non-invasive or invasive, are, let's say, working, then you would, of course, decrease the intensity of support and reevaluate regularly these parameters. In case patients are more hypoxemic or worsening with these strategies, of course, the main question could be that of the sedation of this patient. And actually, this is something very comfortable for us clinicians that help to monitor and to set our ventilator very precisely. But keep in mind, please, that this should not be a goal in itself. Analgesia should be prioritized, and more important, adapting the ventilator first by increasing the inspiratory flow or inspiratory time, for example, should be prioritized to adapting the patient to the ventilator. What about paralysis, neuromuscular blocking agents? There have been conflicting results from trials again, and the current recommendations are against the routine use of continuous infusions of NMBAs in patients with ARF. It could be useful in some, but it's not a recommendation. Prone positioning is well documented and recommended right now in patients with ARDS, with the main goal, as shown by this illustration, of improving ventilation in the more dependent regions of the lung, decreasing the mismatch between ventilation and perfusion, and in that way improving oxygenation. This has been proven by multiple studies, and there's now a strong recommendation to use prone positioning in the patient with the most severe hypoxemia for sessions of at least 16 hours a day, and these sessions can be repeated as needed. What about awake position, plus minus NIV or high flow oxygen therapy? This has been used a lot during the COVID-19 pandemic. There's a lot of evidence to use it, but it can be easy to implement. And if the patient tolerates this, this is something probably that you would like to try. What about recruitment maneuvers, which is high pressurization of the airway during a short, let's say, duration period of time? There is clearly in the recommendation sufficient evidence to recommend against use of these recruitment maneuvers in patients with ARDS, whatever the duration of this recruitment maneuver. Ultimately, veno-venous extracorporeal membrane oxygenation could be an option. And here, clearly, the recommendations suggest using the same criteria than in the large multicenter EOLIA randomized controlled trial published a few years ago, and especially excluding patients with prior durations of ventilation exceeding 7 days. So you have to keep in mind in the first few days of managing these patients that this could be an ultimate option if needed. So what could I say in conclusion? Again, I am insisting on this, but first treat the cause. First, do not bring fluids if not needed. This is really important in these patients. And here is an overall view of the strategy that you could use on both the non-invasive side with high flow oxygen therapy, non-invasive ventilation, or from the invasive side with all the ventilator settings that I can propose in the management of such patients. On this, I thank you very much and hope you will have questions and areas of discussion. Thank you very much.